The organism you are looking at is Mycobacterium tuberculosis. It is an obligate aerobe and a facultative intracellular pathogen. Its defining structural feature is a thick protective layer of mycolic acid in its cell wall, causing it to retain dye and present as positive on an acid-fast stain. Epidemiologically, this pathogen predominantly targets males between the ages of 15 and 45. The infection thrives when a host's immune status is compromised, heavily driven by undernourishment, low socioeconomic status, and overcrowded environments. Inside the body, the disease is an evolving physical threat. It advances from localized nodes in the lung hilum into massive destructive cavities at the lung apex. To manage this progression under the National Tuberculosis Elimination Program, clinicians must map the exact physical stage of the disease to a specific matrix of diagnostic tools. These tests must carefully balance processing speed, pathogen sensitivity, and drug resistance profiling. Surviving an outbreak requires identifying the specific physical location and biological state of the bacillus and deploying the exact test designed to find it. The initial infection takes hold at the lung hilum, forming a localized lesion, a Gons focus. Spreading to local lymph nodes forms a Gons complex. In 95% of cases, the immune system contains it. It calcifies into a Ranke's complex, requiring no treatment. However, roughly 4 to 5% of these primary infections enter latent TB. This is an asymptomatic, dormant state where the bacteria survive inside the host, carrying a persistent risk of future reactivation. In another 1 to 2% of cases, the host fails to contain the pathogen entirely, leading to progressive primary TB. This acute failure typically occurs in young children and immunocompromised individuals. While primary infections generally halt their physical advance, the dormant bacilli trapped inside a calcified complex remain a biological threat requiring strict screening. When a host experiences severe physiological stress or a drop in immune function, those dormant latent bacilli reactivate, triggering secondary tuberculosis. The pathogen migrates to the lung apex. This upper region's decreased blood perfusion provides an oxygen-rich environment where the aerobe multiplies rapidly. The definitive pathognomonic feature of this secondary stage is the formation of distinct cavities at the apex of the lung. The host's own immune system triggers a delayed hypersensitivity response against the bacteria. This causes massive, cheese-like tissue decay, known as caseous necrosis, hollowing out the lung. Inside these cavities, the bacterial load skyrockets. Every cough expels these bacilli, turning the patient into a highly efficient airborne transmission vector. Severing this transmission chain demands an immediate and highly accurate diagnostic response to identify the cavitating pathogen. Under the national elimination protocols, the first line of defense is sputum microscopy. The sampling requirements are rigorous. A patient must provide a spot sample and a morning sample. Each must exceed 5 milliliters in volume and present as distinctly mucoid or purulent. A positive laboratory report requires visual confirmation of red acid-fast bacilli standing out sharply against a blue cellular background. While conventional Zeal-Nielsen stains are standard, modern facilities utilize fluorescence microscopy, deploying auramine or rhodamine stains for significantly higher visibility. The primary clinical advantage of microscopy is processing speed, delivering a definitive positive or negative report in under 24 hours. Yet microscopy is entirely blind to drug resistance. Formulating an effective treatment plan requires molecular data. That data comes from the investigation of choice for all TB cases, rapid molecular testing via cBNAT, commonly recognized as GeneXpert. This is a highly sensitive PCR technique with dual clinical utility. It simultaneously confirms the presence of M. tuberculosis and profiles the bacteria for rifampicin resistance. It delivers this comprehensive resistance profile in exactly 90 minutes. However, cBNAT detects bacterial DNA, meaning it will pick up dead bacilli. This causes false positives in recently treated patients, rendering the tool useless for monitoring ongoing treatment progress. Clinicians support this with other molecular tools, including TrueNat, an indigenous micro-PCR system, and line probe assays for profiling both first and second-line drug resistance. This chart maps diagnostic trade-offs. Sputum microscopy has fast turnaround, low yield. cBNAT provides optimal balance with fast turnaround, high yield. For definitive confirmation, clinicians defer to the gold standard, laboratory culture.
plotted at the highest information yield but the slowest turnaround time. Solid culture on a Lowenstein-Jensen medium provides indisputable proof of the living pathogen, but clinicians must wait 8 to 10 weeks for visible laboratory growth. Automated liquid cultures, such as BACTEC or MGIT systems, accelerate this by measuring oxygen consumption or using targeted immunoassays, reducing the wait to between 1 and 6 weeks. Beyond active infections, clinicians must screen for latent TB. Serological tests for active TB are banned in India, shifting focus to the interferon gamma release assay, or IGRA, and the tuberculin skin test. The skin test involves an intradermal injection of 0.1 milliliters of purified protein derivative. Clinicians measure the resulting wheal after 48 hours. A reading greater than 5 millimeters indicates infection in high-risk patients, like those with HIV, while a 15 millimeter wheal marks a positive result for individuals with zero risk factors. Together, these tools form a complete diagnostic ecosystem. Culture provides ultimate proof, latent tests monitor dormant threats, and rapid PCR brackets active outbreaks. The physical state of M. tuberculosis infection dictates the clinical action. Primary complexes that heal into latency are the strict domain of IGRA and skin testing. Reactivated, highly infectious secondary cavities at the lung apex demand immediate molecular triage through cbNAAT. And when treatment requires absolute confirmation of the living pathogen, LJ culture stands as the final authority. Mastering TB under the national program requires perfectly mapping the arc of its pathology to a targeted diagnostic strike. Only by matching the correct test to the exact physical stage of the disease can clinicians eliminate transmission entirely.